You know that feeling when your stomach hurts and you immediately blame the last thing you ate. You run through the suspects, the gas station sandwich, the questionable sushi, third cup of coffee, and tell yourself it'll just pass. But then the pain moves. It moves from the middle of the belly to the right lower side. Suddenly, every bump on the road hurts. Standing hurts. Breathing hurts. And you're thinking, okay, maybe this isn't just tacos. That's the appendix for you. The body's quietest roommate. It spends its entire time doing nothing. Then one night, it decides to start a house fire. And here's a kicker. Happens to 1 in 12 of us. Most of the time, the only warning is a whisper of pain that turns into a scream. Today, we're talking about appendicitis, why it happens, how to spot it before it bursts, and what your options are once it does.
Views and opinions expressed in this podcast are those of the host and guests, do not reflect the official policies or positions of any affiliated institutions or organizations. Podcasts are informational, educational, and entertainment purposes only, and it is not intended to provide medical advice, diagnosis, or treatment. Listeners should consult their own healthcare professionals for any medical concerns. I'm Brodie Nolan. I'm an emergency doctor.
I'm Josh Levitz, internal medicine.
And I'm James Jung, a general surgeon. This is not another medical podcast.
Last week, you probably can't see, but Thundercat, which may or may not mean anything to you guys, was in Toronto playing at Massey Hall.
It's a show from the 80s, and it was amazing.
Yeah. No, Thundercat is an amazing bassist and hip hop and Grammy Award winner from his most recent album. But he was in Toronto at Massey Hall, so I went to go see. And
very cool.
Halfway through a set, unfortunately, there's actually a medical emergency in the crowd. So, people very quickly alerted Thundercat, again, smaller venue. He saw everything, stopped the show. And so then I was doing my due diligence. I was off to the side, like not on the main floor. But then there's the overhead, is there a doctor? And I gave it the obligatory 5 or 10 seconds. And then the second call came out. And you better believe I jumped over the barricade and then waddled my way through the crowd to check it out. And yeah, sure enough, some guy just passed out. So we helped him out to the front until the paramedics got there, and
you returned to work
to my hospital. And then I returned to enjoy the concert. Missed 2 songs, unfortunately.
Did they give you an upgrade or something?
Oh, definitely not.
Yeah.
No, that's okay. Yeah.
Yeah. we don't do this for the fame.
Anyways,
so
that was my excitement for the week. An amazing concert and a very minor call to duty.
I want the slow-mo video of you jumping over that barricade. Someone's got it.
Yeah, flick your hair.
Yeah. Put some good music behind it. It'll be awesome.
Yeah, pull out your stethoscope midway.
Why? Why did you bring it to a concert? It just doesn't make sense. The acoustics would be way off. It's a weird flex, man.
That's awesome.
That's hilarious.
And James,
awesome.
You were across the world. How was that?
Oh yeah, I was. I can't believe it was just last week, but I was in Singapore for about a week. First time there. I was very impressed with the country. Very clean. I also heard that if you litter, you could get a big fine. They're very strict with littering or drinking or eating in public transportation. So it's complete opposite of New York subway.
Yeah.
So
if you're not littering, people are angry.
Yeah. It's why aren't you littering?
Why aren't you clipping your toenails on this subway?
Yeah, it was actually kind of interesting because on the way back, the transfer was at JFK, and then there were of course overnight delays. And so I had to find the hotel and take the subway to a hotel. And of course, there was somebody who's yelling and screaming in the subway, with cockroaches everywhere. So it was a stark difference between the New York subway and the streets of Singapore.
It was James.
But
James was yelling and screaming.
That's right. It was me. Screw you, American Airlines.
Cool.
How about you, Josh? Did you do anything?
I went to Vegas. I went the other way.
Oh yeah, I saw that. I saw
there you
that you went to the health conference, right?
Yeah, HLTH. It was a big shout out to HLTH. It was an innovation in medicine conference. It was huge. I think it was like 50 or 55,000 people, and it was all about mostly AI in medicine with some longevity discussions in there, and some other really cool stuff. It was amazing. It is so fascinating to see what is out there already.
So they don't call it health, like it's like called
It's
HLTH.
HLTH.
I thought it was a
I may be misremembering. I don't actually think they call it health. I think it's HLTH. Yeah.
Oh,
So,
that's
uh,
disappointing. It's like
I'm-
misuse of that acronym.
Well, I don't think you can just call yourself health. Like,
Why not?
Remove some letters. No one will know the difference.
Like-
It's fine.
I can see
Are you an acronym? Are you not?
Yeah,
it generates discussion there.
yeah. I mean,
There you go.
it's like USAID. I thought it was called USAID. It's just like
Right?
really bad use of the acronym.
It's not.
Yeah. The
Yeah,
whole
it's-
point is to
they call it
shorten how long it
USAID.
takes to say it.
Yeah, it's just like HLTH. I thought it was called
Yeah.
health.
So we're gonna
So,
All right.
James,
Yes.
great topic.
great
Very
topic.
excited for today. Honestly, like, man, surprised we haven't done it yet.
Yep.
But maybe
Brody,
tell us a little bit.
Brody, hold on.
Oh,
Brody, why do you think it's a great
Uh-huh.
topic? I like that. I agree.
yeah. So, I mean, I don't want to steal James' thunder because I'm curious why he chose it. But for me, what I love about appendicitis is it's something that everyone knows about. I'd say, for the most part, and some people are very worried about it when they come to the hospital and thinking about it. But it's also a disease that can be very hard to diagnose because it doesn't always present in the classic symptoms, of which I'm sure we'll talk about today. So it's common and it can present in all sorts of weird different ways, and affects everyone. I love it.
Yep.
I love it.
Yeah, I agree with that. And, it's interesting because, when this entity comes to the surgeon, it's a known entity, right? The mystery of diagnosis is already gone, right? So I thought this was like a topic that I think, Brodie, you'll have a lot to say and your experiences in this. And also it's something, I mean, we'll talk about this a little bit more, but I have a young son. He's a 3-year-old, and in a few years, he's kind of gonna be at the prime age, and like teenage boy, who is the most frequently affected by appendicitis. So I think this is something that would be interesting to review. And as a surgeon, one of the first procedures that you kind of get to learn more and be proficient at is appendectomy. So this was obviously a very special disease if you're a surgical trainee. And nowadays there's a bit of a debate about how to treat appendicitis. So I think there'll be a little bit of interesting conversation around that. So overall, I
Always
think it's
love a good debate.
That's right. Overall, I
Little
think it's a
controversy. Yeah,
great
guys,
controversy. That's right.
this podcast has been a bit too agreeable. We gotta start fighting. Yeah.
That's right. That's right. So
James,
that's why.
do you and the other surgeons ever sit around being like, I remember my first appendix. I remember taking it out and all the joy it brought me, and I knew right then I wanted to be a general surgeon. Is that what you guys do? I assume it is.
I mean, we don't publicly, talk about that, but inevitably, a lot of the times, the first quote unquote solo procedure, like, of course, there's going to be your attending surgeon kind of breathing on your neck, on every move and criticizing every
That
move.
doesn't sound very sterile.
No, actually, not at all.
Don't you guys wear masks?
Yeah.
I think you need a new supervisor, man.
But usually it's the appendectomy that is like one of the first procedures. So certainly, it's a procedure they remember the most as like, oh, this was the first thing that I did as a surgical trainee. So yeah.
So, James, I want to pick up on something that you started off with. Again, kind of bringing back to you having a son and getting older, and we'd already talked about it being a very prevalent disease. Like it happens quite often. And I know you love numbers, so I know you've got some things for it. But can you run through just a little bit of like how often are we seeing this? Like who's getting it? What's
Yeah.
your, is there something like a lifetime risk for people? Like, just how common is appendicitis?
Yeah. It's a very common GI infectious inflammatory disease. It occurs in about 1 in 12 individuals over their lifetime. So that's roughly
That's
about,
huge.
yeah, that's huge. That's almost like
Yeah.
a 10% or 8%.
Wow.
So that's a huge number. When we think about when it occurs in one's lifetime, usually it's in your early years, so adolescents, teenagers, so and early 20s. That's when it's the highest. It's about 250 to 300 per 100,000 per year. And then it kind of slopes down a bit. Traditionally, when I was training, we learned about kind of the bimodal distribution where the incidence peaks up again at later stages, like in their 60s or 70s. But now it's not that anymore. Now it's kind of the decrease of the prevalence, as people get older. So highest peak at the teens and 20s, and then it decreases over the time. And men are more likely to get it, about 40% more likely than female.
Okay, so
So we're almost in the clear.
I'm in the clear. I'm good. I'm out.
Yeah.
Yeah, Josh is
Josh's
good.
right lower quadrant pain is his hip.
Yeah. It's. I know we're laughing, but this is very true.
That truly comes from a place of caring.
No, it
buddy, just so
doesn't. No,
you
it
know.
doesn't. Don't lie to me. Do you guys have your appendix still? I think get a little personal with the
Ooh,
listeners.
this is getting real
Yeah, no,
personal.
it's
Yes,
time.
I am intact.
Yeah, me too. Okay.
I still have my appendix. Yeah, we only need 9 more people to get a one person who has had appendix out.
James, why young people? Why do young people get it more? Do we know?
Yeah, so when you're younger, you have more immune cells. So in this area, in the small bowels, like distal small bowels, so distal meaning the last areas of the small bowels, like small intestines, and then in the colon, the first part of the colon, as well as the appendix, it's really packed with a lot of the lymphoid tissue. So think of it like a tonsil for the gut. So when you're young,
like
you
that.
have bigger tonsils, and then they get smaller over the time. Similarly, when you're younger, you have more lymphoid tissues in those areas of the gut, including the appendix when you're younger, and then they get smaller. Those lymphoid tissues get bigger and bigger and inflamed, activated, and then it closes the lumen of the appendix, and you're more likely to have appendicitis because of that.
Cool.
Yeah, so, Brodie, I'd love to get your thoughts on, or, hear about your experience of seeing these patients who may have appendicitis. You see them, first time these patients come through healthcare is usually through emergency room because they're usually in severe pain. So tell us more about how they typically present.
Yeah, so I mean the textbook example is really it starts off with a vague, dull abdominal pain, maybe kind of cramping, often around like the belly button type of area. And that phase tends to last for sometimes hours, sometimes half a day, sometimes a day. And it's just kind of it's like just it is it gas, is it bloating? It's not very clear, and it's not that severe. But then usually with over again a course of half a day or so, it starts to become quite localized, and it tends to be localized in what we just consider like the right lower quadrant. So kind of towards like the pelvic kind of type region, anyways. And then it becomes really sharp. So now it's on the dull pain. It's very sharp, and then we start to see other associated symptoms with it. So they get a loss of appetite, they might have nausea, they might have a fever or low-grade fever, and then the sharpness of that pain gets worse with things like laughing, coughing, walking, if you're in a car, like when you go over a bump, like all those things where you have that kind of more irritation of the abdominal wall. That's what I'd say the majority of people, or at least if you read a textbook for what appendicitis looks like. Now, I have had people that like come in, look like they have kidney stones, and there's appendicitis. It looks like they've got urinary symptoms, and it looks like they're having a urinary tract infection, and it's appendicitis. Like it really is. Yeah, it can present in all sorts of different ways, which is why I find it
common theme in our podcast. There are textbook findings, and then there are what we see in real life, right?
I was gonna say one of my preceptors said to me, the most common presentation is an uncommon presentation of a common problem, and I remember that stuck with me.
Yeah. Which, if you're a patient, it is way better if you're presenting in a nice, normal way, so we can all like, oh yeah, this is very clearly
right away.
The challenge is when you're not presenting in that classic way. Then it often does take people longer to get to that.
Come on, patients, read a textbook, read a textbook, and present.
I have to say,
to your appendix.
A preceptor also,
a little bit.
I was gonna say, a preceptor also told me to stop blaming the patient. So
I'm digressing a little bit, but these days a lot of the patients have read these textbook outcomes. Whether through generative AI chatbot or whatever, right? So they kind of like list off like, oh, I have this, I don't have this, I don't have this, right? So it's they're quite. It's almost like they went to medical school these days.
Yeah, yep. I will say, for those that are presenting classically, it's like, just kind of seeing them touching their belly, and they kind of like, especially if they've done a bit of reading, we both kind of look at each other and they're kind of like, it's probably appendicitis. And they're like, I know. So it's not a big surprise for a lot of people too often. Yeah. So what might be interesting is, and James, you're probably better able to speak about this, but again, there's really these two phases for pain. There's a generalized ache around the belly button, and then it becomes just kind of focal pain right over top of where the appendix is in that right lower quadrant.
Yeah.
Like, what's the reason behind that? Like, what's happening with that pathophysiology? Yeah.
So we talked a bit about innervation or the nervous system in previous episodes as well. But there are kind of two different, in here, two different types of nervous systems. So one is the visceral nerve. So when I think about visceral nerve, I think about inner layers. So, this is where the pain that is in the gut. So there's an inflammation of the appendix, and that inflammation will cause irritation in the visceral nerve. But the visceral nerve doesn't pinpoint exactly to where that area is, or we don't have the perception of where that exactly is location-wise. So it does have that more dull, general, sensation of discomfort. But then when that inflamed appendix touches the peritoneum, and that is in the inner layer of our abdominal wall. So if we think of, our abdomen as a room, the appendix is there and it's touching the ceiling of the room, and the nervous system there has a better perception of the location of that area.
Gotcha. And this is what makes medicine a bit difficult, in that it is so rare we have something that actually focuses on the area that it's happening. We have all this referred pain, where pain in the diaphragm area can show up in the shoulder, or pain here can be very diffuse at first. And it does make diagnosis of these and many other issues hard. And that's just for patients and people listening. That's why doctors are often, we don't know, because things don't present exactly where they are and how they're supposed to.
Yeah. And the other thing that I want to pick up on what you said there, James, was, if that inflammation, that stretch of the appendix, a lot of people will kind of say, I just thought it was gas. I just thought it was cramps. But it makes sense, because that's exactly the nerves and stimulation they're having as when they have gas and their bowels a bit dilated or distended from that. So it does often feel like gas, or like a bit of like a belly ache sort of thing, because it actually is the exact same nerves that are causing that.
Yeah, the visceral sensations. Yeah.
Do you guys want to talk for just a minute about the kind of less common presentations, or the atypical presentations, about what we could see?
For me, I always think of the really young and the really old. And part of that is just I think the challenges and sometimes localizing. So often with kids.
Brodie, what do you consider really old?
Older than Josh.
Careful.
Older than me. No, I won't give an exact age to it because we know that everyone is different. But to that, I think the reason for both as kids and as adults, older adults, it can be hard sometimes to communicate where your pain is because you're also like this is new. I don't really know, just my belly hurts. Or so they
Mhm.
might present with other symptoms then, right? They've got vomiting. Maybe it's they're refusing to walk because it hurts to walk, as we talked about beforehand, especially when the lining of the abdomen, the peritoneum starts to get inflamed. They might just be more lethargic, kind of fevers. So you do have to look for it a little bit more in some of those populations, especially people that are, unable to speak, nonverbal.
Mhm.
I also think about pregnant patients. Again, especially if you are quite far along in your pregnancy, that just displaces everything. So your uterus takes up a whole lot of space there with your baby, and that pushes your appendix around. So sometimes, like they present with back pain. Again, it might
Mhm.
almost look more like a kidney stone type of presentation, or like higher up in the back. That's just because things get moved around when it's in there. Um, uh, yeah, those would be some of the, like I said, the populations I think of. I don't know,
Yeah.
James, if you got any others.
Oh, just to kind of comment more on the kids with appendicitis. So when we rotated through Children's Hospital, we get a lot of these, consultations about appendicitis in kids, and you could almost like with high accuracy guess who actually has appendicitis and who doesn't, even before the imaging, just by how the kid is behaving. So the kid with the appendicitis will be like silent, like, does not want to move.
Yeah.
Whereas the kid who doesn't have appendicitis will be speaking to you and say, oh, like my tummy, or like, oh, I think blah, 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 or like walking around. That almost certainly, does not, we don't see appendicitis, whereas the kid who has appendicitis just like doesn't want to move. And
So,
one of the big tests is like you shake the bed of the kid. I mean, we don't do that on purpose, but it's kind of
Yeah.
early.
Don't shake
yeah.
don't shake the kid.
Don't
Do
shake the
not
kid.
shake the children.
Yeah.
Shake the bed.
Shake the bed, or just tap the bed a little bit, and then the kid will be like jumping out for with pain. So not to be mean to the kid, but it's a good sign that whether this patient has appendicitis or not. Josh?
And you just gave me another parenting tip on how to keep my kid quiet. Just
God, that turned dark.
appendicitis.
Shake the bed with
I,
the appendicitis.
I still think that sign came from like a very clumsy surgeon.
Yeah,
He was
just bumped into
like
the bed.
constantly bumping into beds. They're like, this one probably has it. Like, yeah, yeah. It's like, who was the first person that like really went on to shake that bed? I don't know. Anyways, kudos to whoever it was.
Yep. Right. So maybe it's an unfair question, but when should people go to the emerge? Like, what kind of symptoms would say go to the emerge, even if you don't know if it's appendicitis?
Totally. And I think, again, a common theme of the podcast is like anytime you're worried, you should probably go and see someone because we have the benefits of blood work. And really, for this, you need advanced imaging. So it's usually an ultrasound, sometimes a CT scan to figure this out. So for me, like worsening pain, abdominal pain and fever is always a red flag. A pain that has signs of that like irritation of the peritoneum. So this is pain with coughing, with walking, with movement. Those are all things that I get really worried about. And it's important because, for appendicitis, like timing matters, right? Like the sooner you can get diagnosed, the sooner you can get treatment, it really does put you at risk for things if you have delays to your care. And James, I'm sure you'll kind of dive into that. So maybe that's a good time to pivot, James. What's actually happening? So like what's happening in appendicitis and what are you seeing?
So appendix is like a cul-de-sac. It's a blind end pouch. So I actually, when I speak to patients about it, off of the cecum, which is the first part of the colon, there's a little pinky finger that's just projecting out of that cecum.
Aw,
so that
that's so
is the
cute.
appendix. Yeah, it's a cute little thing.
Most of the time.
Most of the times when it's not angry.
fair enough.
It's narrow. It's blind-ended pouch. And as we talked about before, whether if you're a kid, you have a lot of lymphoid tissue, and that lumen is the inside, area, is narrowed even further because of the thickened lymphoid tissue, or there's a poop ball It's called appendicolith, but really it's a poop ball that just
Poop ball.
gets lodged. Poop ball just gets lodged in there in that opening, and it just blocks the fluid that's produced in the appendix from draining. And what occurs when there's blockage, there's distension of the appendix, and there's bacterial overgrowth. And as the appendix becomes more bloated and bloated, the blood supply to that gets stretched, and it becomes ischemic or starved of oxygen and blood, and the tissue dies off and becomes necrotic, and then it creates hole, and that hole will exude all the bacterial overgrowth or poop, and that makes you unwell and septic, or feeling quite sick. So that's kind of the effect of what's happening.
And where does all that stuff go once it starts leaking out?
Just to the abdominal cavity, but it's not that it will just freely go everywhere, often not, but it forms sort of the abscess, so kind of the purulent pus, and it kind of gets walled off. Body does an amazing thing to stop this infection, so it just walls off everything with all the neutrophils, all of our immune police cells will kind of go there and try to wall that off. But that does become source of infection and source of sickness. And that's what happens.
There are so many good visuals for our upcoming live action comic.
Yeah, that's right.
Yeah.
Brodie, you talked a bit about the timing. So maybe,
Yeah. I mean, James, with that, so you talked about the risk for perforation. Again, you get this increasing swelling and stuff in there. Like, what are the timelines that you see? Like, how someone comes in, we're worried appendicitis, we need to do some workup and stuff, but like, what does that risk of perforation look like?
So because the process is somewhat sequential, that there's blockage, obstruction, and then distension, and then necrosis, and then hole, the longer you wait, the more likely you're going to have perforation. The perforation is it's a before and after perforation in a way in the world of appendicitis. And we'll talk about that a little bit later, but before perforation, treatment is simpler. After perforation, treatment is more complex. So, the risk of perforation is about or less than 10% if within 24 hours of the start of the symptom. That risk of perforation goes above 40% after 48 to 72 hours of symptoms start. So the longer you wait, the higher chance of perforation and the worse consequences of this disease.
Wild. Now, I want to sideline to a question that we've all had and we've all asked, and then we'll get into diagnosis and all that after. But this is the important one: why the hell do we have an appendix? What does it do? And do we need it? And I think things have changed over the years, because I remember in med school, it was always like, we don't even need the appendix. Why don't we just take it out on everybody?
Yeah, that's why they called it appendix.
Yeah, there you go.
Yeah, so, I mean, I've, we went through medical training together. We learned that this is just useless vestige from, for some reason, it kind of stayed. It kind of fought off the Darwinian evolution to stay with us. And they, Darwin himself actually proposed that it's kind of the shrunken remnant of a larger cecum that sometimes we see in cattle or herbivores.
Well, wait, are we about to disprove Darwin? Are we going to be even more groundbreaking?
Oh, well. Well, this is where the controversy comes in.
Okay, sorry to interrupt.
But I think there's a new view. I mean, it hasn't been completely proven, but there's some emerging evidence that, and we talked about this lymphoid tissue, that, appendix, when you look at it microscopically, has a lot of lymphoid tissue. And this is part of that gut-associated lymphoid tissue area where it plays a big immune roles, and certainly it has a role in microbiome reservoir. It has a role in mucosal defense. So mucosa is the inner lining of the gut. So
that's where our gut sees or interacts with outer environment, right? So whatever you eat, consume, that bacteria that you consume through mouth or through anus, that comes in contact with the inner lining of the gut. And we believe that the reason we don't get sick all the time is because there is immune police that it has a surveillance system of the gut. And appendix is one part of this. It may not be it's not the key part of it, but it plays a role. And that's why when we look at anatomy of over 500 mammalian species, that appendix continues to kind of stay, continues to be there for a lot of the species, even though once they appear on the species. So it does have maybe some survival benefit to have the appendix, although it's not
maybe
true
not
for
so
humans
much
now.
it may not be like the leftover remnant, but actually a survival benefit as opposed to slowly getting rid of it over time.
Yeah, I mean, it may be a leftover remnant, but it just plays it plays maybe not potentially survival benefit, but it's not a disadvantage to having this, right?
And
I think
Darwin's maybe not wrong, but there's more to it.
Yeah,
there's more.
And the appendix just needed a better PR guy. Guys, I have another controversial theory in that the appendix and the gallbladder are still around because general surgeons need jobs. And without them, they'd be out. I know it's controversial, but I think it's correct.
Yeah.
That's some very deep state.
Human evolution, centers around surgeons.
It's the god that James is. He makes sure that he always has work lined up. So Jim, maybe just to confirm what I think you were kind of saying gently there before. So the appendix might play a role in some of these things, but people can also have their appendix taken out and have had their appendix taken out for a long time and live perfectly fine.
That's right.
Like there's no real big changes at the end of the day.
That's right.
So,
okay.
Because there are other things that are doing the same job. There's some redundancy.
That's right. Yeah. So exactly. That's exactly it.
Cool. All right. Let's get into the cool stuff. You come into the emerge. You think you might have appendicitis. How do we diagnose it? Because that's the fun stuff. That's what patients want to know. What are you guys doing?
Yeah. Yeah, and there's all sorts of different physical exam findings, and you look at vital signs, and they have a fever, is the heart rate elevated, and there's different scores that have been developed to predict your likelihood. That being said, I'll be honest, for me, I work in a place that I have ultrasound imaging and CT scan imaging available, and I think that the potential of this is missed for badness is quite high. So if I have anyone that has any sort of persistent, reproducible pain when I press down on the right lower quadrant, I'm moving on to imaging. Yes, you can look for things like an elevation in their white blood cell count on blood work, which is again more of a systemic signs for infection and inflammation, but that's not perfect. There's no physical exam finding that's perfect, and it's a common thing that presents in a bunch of uncommon ways. So I think a lot of the time, anyone that has reproducible tenderness down there, they're going to get imaging. And then for us, the imaging decisions, there's kind of the pros and cons to each. There's ultrasound and CT scan imaging. Ultrasound is nice because there's no radiation, I guess is really the biggest key. So especially with people that are younger, it avoids that radiation, that longitudinal maybe increased cancer risk or things like that you might have with a bunch of CT scans over your life. The downside to ultrasound is that it doesn't always show the appendix. So it's not uncommon. Sometimes we'll do the ultrasound first. You can't find the appendix. And then we have to go on to doing a CT scan afterwards. A CT scan, is a bit more expensive from a cost perspective. There's some radiation exposure that happens, but usually has a pretty good chance for picking up appendicitis. So that's typically my go-to. Ultrasound if they're young, not a lot of other risk factors or things I'm thinking about in my differential. But if they are of an older age, I'm worried about maybe things that might be more like a cancer or a bowel obstruction or other things like that, then I might move on to doing a CT scan first.
And you guys may or may not know this, but we all work in kind of resource rich settings. We have the CTs, we have the ultrasounds, we have whatever we want. Do you know if you're in a rural area, you don't have imaging, you kind of present maybe not appendicitis? James, do you know, like, are they going to surgery pretty early? Are they shipping to a bigger center? What's happening?
Yeah, so I think for that precise reason, and because the CT scan wasn't as widely available back in the days, we really depended on these kind of scores. One that we learned about a lot and still to some degree use in practice is called the Alvarado score. So if there are a few symptoms like the pain pattern that we talked about, or if really the patient doesn't want to eat even though they're hungry, if they're having nausea, vomiting, or fever, and that tenderness in the right lower quadrant, if you draw an imaginary line between your belly button and the bony prominence of your hip on the right side, and that kind of midway or a little bit more to the bony prominence, that's where we're talking about the right lower quadrant, or McBurney's point. And the physical examination we do are centered around that area. So if there's a tenderness, we call it peritonitis, where it's quite tender, and the patient, when I press, will want to punch me. Those are kind of the signs, not because of what I've said, or those are kind of the signs that, that will that will tell us that there's a high likelihood of appendicitis even before ultrasound and CT. The other kind of factor is that if it's a young, otherwise healthy man, and you have all these history, examination, finding, let's say in low resource or medium resource rich resource setting, that does not, or if the patient does not want to pay for ultrasound or CT scan, I think that's a high likelihood that this is appendicitis, just given the prevalence that we know. Versus if it's a female of certain age, we do have to make sure it's not other things like ectopic pregnancy, or any ovarian cyst torsion, or things like that. There are a lot of other things that could present similarly, that if we miss that would be detrimental. So I would be more careful if I'm in a rural area without CT scan and ultrasound wasn't really working, of going straight to the operating room for female, versus for men. I think there's a higher chance that this is appendicitis.
Mm-hmm. Gotcha. I think it's part of our practices that we don't know as much about, because again, we have whatever we need.
Yeah,
so,
we always have CT scan,
ultrasound,
everything.
Yeah.
So James, with that, let's say someone is confirmed with appendicitis, they either have an ultrasound or CT scan. What's you talked about some different, to take the operating room or not. Like, what are you doing? What are your options once you've been told, hey, you've got appendicitis?
Yeah, there are a few ways to think about it. So first of all, the treatment option one is surgery. I think that's the mainstay.
You always say you always say that, okay? Come on.
Got a scalpel, you can cut something.
Well, if you listen to our hemorrhoid episode, I said no surgery. I said the rubber band.
I stand corrected appropriately.
Yeah. So surgery is the mainstay. So surgery these days mean minimally invasive. If we do it laparoscopically, it usually involves 3 little incisions. Now there are more and more minimally invasive techniques like single port appendectomy, where you do it all within one port, so one just small incision. Either way, they're all very small incisions. It does take general anesthesia, but it takes about less than an hour to do the operation. Really quite safe operation overall, very low complication rates, and the benefit is it's one and done. Appendix is not going to grow again just because you pruned it.
That sounds like a challenge.
So unless
it's all over right now listening,
unless they left like a huge appendiceal stump left. Maybe you could have stump appendicitis, and we've seen reports of that. But if the surgeons had taken out the appendix appropriately, then there's no chance of this coming back. So those are the advantages. And often patients stay in the hospital for 1 day or less than 1 day if they're well and go home. So,
Wow.
you could come into the emergency room at night and get the surgery in the morning and go home at the next night. So that's kind of the way. The second, and this has always been around as an alternative way to treatment, and there's been a lot of randomized controlled trials to compare to surgery, is using antibiotics. So the patients who are diagnosed with appendicitis will all get IV antibiotics to start the treatment. But in this cohort, they're advocating for just antibiotics only as a treatment. So instead of having surgery. And this we reserve for patients who have something called the uncomplicated appendicitis. So there's uncomplicated appendicitis versus complicated appendicitis. Complicated appendicitis is appendicitis that has perforated or that has abscess, that has fluid around them. Uncomplicated are those ones who have inflammation, dilation, but none of those perforations or anything like that. And another key factor that we use to select for patients for antibiotics only is that they need to have that, they should not have that poop ball that I talked about. So no appendicolith. If you have poop ball, we recommend surgery. No poop ball.
Surgery.
Yeah, that makes sense to me.
Yeah.
Right.
So poop ball is a really important deciding factor in this. So there's antibiotics only approach where if the patient and the providers have decided that this is what they want to do, then instead of having an operation, they'll get IV antibiotics and then transition to oral antibiotics for usually about 7 to 10 days.
What percentage of those people will go on to have an appendectomy?
Yeah. So that's the important downside of antibiotics. There's one big trial that was published in New England Journal of Medicine called CODA trial, involved 1,500 patients, and about 70% avoided surgery at 90 days, like since the initiation. So that means 3 out of 10 ended up having surgery in that time period. And most of them within 30 days of the antibiotic treatment. So you do have that failure of the treatment that leads to another treatment to take over. And that to me is the reason I advocate mostly for patients who are healthy enough to have surgery, because, it's not while you're on this treatment with antibiotics, you're staying in the hospital for a few more days than if you were to have surgery. And you have to kind of live in a fear that this may reoccur, and you have to come back to the emergency room if you're home already, and you worry whether there'll be a perforation or not, which will be more consequential. So these kind of, and then there are meta-analysis, which are just pooling of all of the randomized controlled trial data that have demonstrated that that 30% failure or transition to surgery still holds. It's about 20% in a lot of these studies when you pull them together. So this is a real, percentage of people who do end up need another treatment.
And 30% is huge. 30% is huge in the medical world.
Yes.
Yeah.
So
if your treatment only works 70%, like 7 out of 10 times, that's not a great treatment.
Yeah.
Yeah. Unless you're a hitter in baseball, then you're best in
the league.
Best in the league, yeah.
Yeah. Also, when you said poop ball, I was literally just about to eat my daughter's Halloween Smarties, and you said poop ball, and I just put it down because it's too close.
You don't want to have appendicitis.
So it sounds like surgeons are still safe. You're not being totally out of a job for IV antibiotics for appendicitis.
Yet, unless they come up with the new IV antibiotics. No, I think surgery is really the mainstay for this disease, especially as surgery becomes more minimally invasive, which they have become, right? So, back in the days when it was open surgery, you need to stay in the hospital for like 5-6 days. I mean, it's not that long usually, but let's say 3 to 4 days after surgery. And the full recovery is even longer versus, you have 70% of success being completely off of this with just antibiotics only, stay in the hospital for 2 to 3 days. Maybe there is a role for antibiotics, but I think more and more, surgery is becoming more beneficial.
Mm-hmm. Cool. Yeah. And Chief, you talked about kind of complicated appendicitis, but I'm assuming then, for patients that have a delay in the presentation, there is a perforation. It's a much more complicated surgery. It's a longer time in hospital, but then also carries all the other risks. You have bacteria and pus in the abdomen that can get into the bloodstream. You can get sepsis and organ failure, and some people die from appendicitis. Like, it's still like, although we talk about it's common and it's surgery and you're home in a day, like the miss, if it's not diagnosed or you don't get those antibiotics or surgery, again, this can be something that people can die from.
You could get quite unwell,
to present early.
And you could fall off the the physiologic reserve, and then you could, especially if you have underlying diseases. So that's important. If it's complicated appendicitis, depending on where you are and depending on the number of days and depending on CT scan findings, you may not get an operation as well, or you may be treated alternatively with like drain and things like that, cool it down, and then operation down the road. But it's not going to be antibiotics only if it's a case of complicated appendicitis.
Yeah, that's the other fascinating thing about the body too. Is I've had it where like patients have walled off this abscess, and they're not small necessarily. Sometimes they are, sometimes they're not. Yeah. But then it's just this giant area of pus that's just like walled off from everything else inside, and they're not like super sick, and they just have this vague abdominal pain still. But again, the humblingness being faced with appendicitis.
Absolutely. Even appendix surgery in setting like complicated appendicitis can be humbling, can be technically challenging. When there's an abscess like that, it's like cement. It's very hard. It's hard to know what is GI tract and what is pus in that area. All the GI tract becomes very friable. Everything you touch just bleeds. So it could be a very humbling operation. So for that reason, and can carry high perioperative complication rates. So for that reason, if it's been there for a while, abscess, perforation occurred, 4 or 5 days ago, and so forth, and the patient is not having severe septic shock, then we would try to drain it, get the badness out, antibiotics, and then get them better from with that approach.
And I don't know numbers, James, but I'm guessing the majority of these do really well post-op, have a great recovery, don't even know they had it 2-3 weeks
uncomplicated appendectomy, yes.
Just the majority of them,
yeah, the vast majority do quite well. Complication rates are quite low.
Cool. Well, guys, looking at the time, I think we go to our favorite new-ish section of this, the myth-busting section.
We still need some theme music. We get an air horn.
We need a catchy name for it.
Gotta get amped up.
We need a catchy name.
Yeah.
Like,
maybe it'd be like MTH.
What's that? Oh, I get it.
That is incredible. MTH it is.
MTH, guys.
MTH.
All right.
MTH.
I love it.
All right. Well, you know what? I'm just going to start with the first myth because we kind of already talked about it. But the myth that, I had pain. The pain's gone now, so I'm fine. I don't need to see anybody. What do you think about that, James?
Yeah, so there may be a brief period of time in which you had severe pain and then the pain dissipates a little bit. And sometimes that gives people relief and that, this is all gone away. But sometimes that could actually be a time when perforation occurs. So if you've had severe pain, fever, all these red flags that we talked about, you should go to the emergency room, get checked out.
Gotcha. So don't trust your body. I like that.
Trust your body, but don't trust the myth.
There you go.
There we go.
I like
Right.
it.
Yeah. Yeah. I mean, the other thing, James, you talk about the appendix sometimes being blocked from stuff. So, are there any home remedies? Can you massage your poop ball out? Can you poop out your poop ball? Drink it out, like just a lot of carbonated soda. Are there any like home methods
Yeah,
that people can do?
some people, think whether they could kind of massage like that area to get the poop ball out. Unfortunately, there hasn't been any, home remedy that's shown to be effective in treating appendicitis. It's really just bad luck, with this poop ball. Just happens to be in the wrong place, wrong time. Just like gallbladder, gallstone happened to be at the wrong, place, wrong time, blocking that that little narrow lumen. Really, it's unlikely. But sometimes that poop ball can kind of dislodge on its own. And it's not because you've done massage or kombucha. Or go lightly.
Good call.
Yeah, it's just the bad luck.
Fair.
Yeah, I do enjoy kombucha.
Yeah, very very good.
Oh, God.
I have nothing for that.
This is what happens at the end of the podcast, isn't it, guys?
Yeah, that's right.
We all slow
We're
down.
done.
We all slow down.
The
All right.
energy is not there.
Last myth, we've already kind of answered this one. Appendicitis always causes pain on the right side, lower part of the belly. And I think I can, I'll just take this one. No, we said there are some atypical presentations, depending on who you are and what age you are and what other medical things going on. So that's the classic presentation, but not the only one.
Nice.
I just,
All right.
as the
I think
as the internist of the group who does not see appendicitis ever, like I can't even remember the last time I saw it. I had to pretend I know something about it.
Nice.
That was a good myth busting, Josh. I'm very proud of you.
Mhm.
Thank you. I will stop talking now.
All right. Should we take it home?
The appendix,
Wrap up.
or
Yeah.
Do you give it to
Yeah.
your patients after you take it out? You give it to them. You're like, take this home.
Yeah, actually, some people
Yeah,
ask
is it-
ask for things like that, like, "Oh, can I get the gallstones?" Unfortunately, we send it to the pathologist, and we would have to ask the pathologist what they do.
You
with
tell
that.
you tell them to call the pathologist.
Yeah, I tell them to call the pathologist.
But you
Go to the
never
dark
want to go
room.
down there on your own.
Yeah, go to the dark room.
Which also, what did they do with it? I mean, like we said, I won't tell you the things we said
yeah,
to pathology.
I'm sure
but,
there's some protocol.
Like, I'm always curious. What are they?
Guys, we're going
Yeah,
tangential
we-
here. We're going tangential.
All right,
Let's bring
all
it
right.
home.
Let's bring it home.
Yeah.
Okay.
All right.
All right. I'm calling first. Okay. So my take-home message: appendicitis is common. Again, 1 in 12 people. That is insane for your overall lifetime risk. So it's common. Listen to your belly. It's something that you should be up there thinking about. And if you're having the abdominal pain, especially if it's starting to localize in the right lower quadrant, come to the emerge
Yep.
or whatever your appropriate healthcare facility would be.
Yep. And I think just to follow that on the take-home messages, timing matters. So don't just wait to see if things disappear. If it's getting worse, you want to get to the emerge or wherever you're going as soon as possible. The longer you wait, the bigger chance of poor outcomes.
Yeah. And last point is, while antibiotics can be effective to about 70% of the time in select patient groups, the mainstay treatment is minimally invasive appendectomy or surgery to take the appendix out. These are very safe, very effective surgery. So don't be too afraid.
Yep. And it keeps food on James's plate. So can't forget that one. James, that was such a great topic. So much fun to talk
Thanks,
about. So
man.
important.
Great. Yeah, the great
This is
topic.
good.
Yeah, this is great to share this with you, and great input from both of you, especially Josh.
Thank you. I needed the boost. All right, boys. We'll see you on the next episode, okay?
Thanks, guys.
All right.
All right.
Great talk.
Pleasure. See ya.